All right, I have an interesting case for you guys. Okay, this case comes from one of our third years, John Rarucha. I'm probably saying that name wrong, and I apologize. I'm mentally handicapped when it comes to words. For some reason, my brain stopped developing the ability to pronounce new words or new phonics like after the age of 2. So if it's something complicated, I can't pronounce it and or remember it. John's a good dude. He signed with EP&O. He also agreed to work all of the shifts I don't want to work for the next 3 years. If he denies that, it's on the internet now, so it's true. So you can suck it, John. All right, so I looked up his name. It's a Czech name, and it means watercrest, which is a topographic origin name, which means like his people probably lived near water. It's also with Old Germanic meaning sharp or spicy. The Czech variation, the broader meaning points to a fast-growing edible herb with healing properties, symbolizing vitality. John's got a lot of hair. I propose that we cut some of his hair and eat it to see if it gives us healing properties or vitality. So watch your scalp, John. Coming for you. All right, so here's the case. Remember, we don't treat an EKG, we treat a patient, and the value of any EKG depends on your pretest probability. So this is a 60-year-old female with a past medical history of hypertension, not on medications, presenting to the EMS for cardiac arrest. Pre-EMS, patient was outside shoveling snow when she had a witnessed cardiac event. I've seen many people die while shoveling snow. That's why I call it the White Death. Patient was found by EMS apneic and without a pulse. Oh no, another victim of the White Death. CPR was started immediately upon arrival with ROSC after 2 doses of epinephrine. Pulses were lost for a short period, but ROSC was regained after 3rd dose of epinephrine with CPR. EMS reports the patient was intubated and placed on a ventilator while in transit. At 11:17, patient arrived at the ED in the trauma bay with Lucas. Pulses were confirmed on arrival. EMS reports families presenting and awaiting consultation. Highly concerning for a cardiac event, correct? Shoveling snow, collapsed, lost pulses. Now we have ROSC. Husband and sister were consulted at 11:30. Husband reports a Ring camera recorded the event where it was seen the patient began to lean forward and suddenly became limp. No slip or trauma was witnessed. Sister reports earlier today the patient was complaining of a minor headache. Husband denies the patient having any other complaints prior to the event occurring. He notes no recent illness. This is a great job by John to get more information, more data. For this patient, the patient themselves can't tell you anything, so you have to rely on secondhand information from either EMS or the family members. EMS is valuable, but it's always best to get the information straight from the source. So it was a good job by John, and it was good that it was done relatively quickly. I mean, she came in at 11:17. Like one of the first things he did was talk to the family to get more history to help them delineate, well, what's going on, right? Like we need this pretest probability to help us interpret what the abnormalities on EKG means. All right, here's the EKG. We have nothing old to compare it to. I recommend you pause, think about what your findings are and what your interpretation is, and your interpretation is the action of explaining the meaning of something. So here's what I see. Okay, I always start with the rhythm strip, which is always lead 2 or V2. Those are the best place to see P waves. I'm not really seeing many P waves here. Maybe there's a P wave there. I can see one there. Okay. Am I seeing any other ones? Oh, I think there's one there. Okay. I think there's one there. I think there's one there. I think there might be one there. Maybe there's one there. I don't really see many clear-cut P waves. Let's see if we can extrapolate out. Because remember, all these beats are the same. If this is a P, then that's a P, then that's a P. Okay, there's one P. If that's the P to P interval, is it staying the same? Is there another P buried somewhere in here? Maybe. Is there another P? Oh, I think there's a P there. Extrapolate out. Is there a P? Maybe. Maybe a P in there. A P. Okay, so that's my P to P interval. Okay, and for me, it's not changing much. Okay, so I see a P to P interval with, and let's see, when we see these P's and these QRSs, let's look at this one. Okay, there's one PR interval. Here's another one. They're not really consistent. Okay, so I don't really see any communication between the atrium and the ventricles. Let's look at the rate. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. 20 times 6 is 120. Okay, so we have a wide complex with no discernible P to QRS relationship. It's less than 130. I'm calling this an accelerated interventricular rhythm. That's what I'm calling this. Am I completely correct? I don't know. You can debate it and talk to many electrophysiologists, but that's what I'm calling this. Okay. So we have an accelerated interventricular rhythm. For the axis, it's up in AVF. Oh, let's look at lead 1. Okay, let's see. We have 1, 2, 3 boxes up. Let's look at the down. 1, 2, 3. It's like equivalent. So we have borderline right axis deviation. Okay, and again, for me, anytime someone's super sick, I'm always concerned when there's a large S wave in lead 1. So that piques my interest. Like, it's not diagnostic or anything, but that makes me concerned for a couple things. Okay. For the intervals, I do see a complete or a widening of the QRS greater than 120 with an RR prime in the precordial leads consistent with a complete right bundle branch block. Okay. Again, I usually defer to the machine for the QTC interval, but you can clearly see that the T wave falls more than halfway between each R wave, so the QTC is prolonged. Okay, let's look at the ST waves. We do have some J point deviation. You can see up here in lead 1, we have maybe 2 millimeters of depression. And again, remember for these right bundle branch blocks, always keep track of where the QRS begins and ends. Begins up there, we know it ends up here, so we do have like 3 millimeters of J point depression with this straightening of the ST segment here. Same issue here, J point depression with repolarization abnormalities. Up in AVR, one would be tempted to call this J point elevation, but remember, keep sight of where the QRS begins and ends. There's our J point there. Not real significant J point deviation. Again, you can see this significantly prolonged QT. In AVL, I don't really see much J point deviation. I do see slight J point deviation and linearity in AVF. And again, a common pitfall residents fall into is when we're talking about right bundle branch blocks, they want to use the terms concordance and discordance. That's false. Don't do that. Okay, concordance and discordance only applies to complete left bundle branch blocks or ventricular paced rhythms. Again, up here in lead 1, I'm not seeing much J point deviation. Here in lead 2, I do see J point depression and this linearity repolarization abnormality. Same thing here in V3, like significant J point deviation, and again, this linearity downsloping ST segment, which is concerning. Remember, in a right bundle branch block, slight ST depression or T wave inversions can be normal, but this is not slight. Like, look at this. Like, this amount of J point depression here is greater than the amplitude of the R wave. Like, that's way more than it should be. Same over here in V4, we have significant J point depression with this straightening repolarization abnormality. Same thing here in lead 5, same thing here in lead 6. Okay, so my overall interpretation is an accelerated ventricular rhythm, borderline right axis deviation, complete right bundle branch block, prolonged QTC, diffuse repolarization abnormalities, repolarization abnormality in almost every lead. Okay, so if you've seen my previous, what Patrick, what are you doing? If you've seen my previous videos, this is what I refer to as a diffuse repolarization abnormality, right? Like, there's a repolarization abnormality in every lead, a diffuse repolarization abnormality. And for these people, when they're super sick, you got to think of one of 4 things, okay? The first one is coronary artery disease. And when we're talking about coronary artery disease, you have to distinguish between a type 1 and a type 2 infarct. A type 1 infarct is an occlusion of the vessels that needs to be fixed. A type 2 is a mismatch. You often see these in people who are like anemic and or septic. They have underlying coronary artery disease, which causes the EKG changes. The problem is a mismatch, not an occlusion. For 2, it's tox, okay, and those are both prescription drugs and street drugs, anything that affects the sodium channels, the rectifier potassium current channels, or connexin 43. Antipsychotics, antidepressants, cocaine, antihistamines, the list is many. 4 is metabolic, and the 2 ones to think about is either hyper-K or acidosis, okay? And again, because those affect connexin 43. And the last one is the brain, like significant brain problems. So when we think about the pretest probability for this patient, okay, what was given, I don't think tox is like highly on my list, and neither is metabolic, right? That doesn't make sense with what's going on. The top 2 are definitely coronary artery disease, and the second one would be the brain. I don't think it's a type 2 infarct. Again, if this is coronary artery disease, it's a type 1 infarct. Now, the thing that helps us delineate here, and we'll see, is the history, okay? So rightly so, they called the STEMI, talked to the cardiologist. Before we talk about what happened, let's look at some of her labs. Okay, first troponin 114, second troponin 1,533, third troponin 3,690. Okay, concerning, right? She was a victim of the White Death. She has EKG changes. She has an elevated troponin, concerning for a type 1 coronary artery occlusion. But remember from the history, uncontrolled hypertension and complaining of a headache. The cardiologist is like, I agree, we should take her to the cath lab, but before we do, let's just scan her brain real quick. And this is a CT scan of her brain. Very bad subarachnoid hemorrhage. Unfortunately, the patient did not live. So the question here is, why do we have all these EKG changes when the problem is with the brain? And the answer is connexin 43. Remember, connexin 43 is a gap junction protein, and it's found in high concentrations in both the heart and the brain because they carry a lot of electricity, right? I use the analogy that these are kind of like the watertight doors on the Titanic. What happens is, as a result to injury, what they do is they shut down to limit the spread of apoptotic signals from one cell to the other. So the goal is to keep the healthy cells healthy and let the dead cells die. As a consequence of that, we see problems with electrical conductivity, resulting in both clinical manifestations of confusion, seizures, altered mental status, cardiac arrest, and EKG abnormalities that we see on the actual EKG itself. Same thing, here's the connexin 43 channels in the brain. And again, for this patient, my contention is what happens was the acute insult to the brain called the connexin 43 channels to shut down to limit the spread of apoptosis. Those chemical signals and those messengers are not limited to just the brain. They diffuse throughout the body and affect the connexin 43 channels in the heart, resulting in these repolarization abnormalities on the EKG and elevated troponins. More indirect evidence of that, it can be found in the literature, which I've referred to before. We know that connexin 43 plays a role in ischemic problems in the heart tissue, as well as in subarachnoid hemorrhage. Again, there is a way to confirm this. For these labs, what they do is they take mice or rats and they occlude the internal carotid artery and they do Western blots on the brain. I would love to talk to one of these labs and just say, hey, next time you're doing this, can you just also do Western blots on the heart to see if we're on the right track? But I don't know any of those fancy nerds. If anyone does and has a connection, let me know. So that's all I got for this case. Remember, this was a case of a diffuse repolarization abnormality. When you see that, think those 4 things. And remember, you don't treat an EKG, you treat a patient, and the value of any EKG depends on your pretest probability. That's all I got. Good work, John. Patrick out.